Let's continue. Um, Actually, no. Hmm. So we have a new topic which we have to do. Medicine, I feel I've done enough, and I don't really want to do anything more. So let's continue with surgery. Shall we? So these are all the topics that are there in surgery, and the first chapter is one of the most important one: wound and wound healing. So we talk about hematoma. This is important, and phases of wound healing. This is also important. Crush syndrome, not that much. Hypertrophic scar, keloid compartment syndrome. All of these are very much important topics in surgery. So, Magellan's ulcer, infectious disease, strike, tetanus. A lot of small topics and very important topics are there. So, okay, let's start out with hematoma. Hematoma is localized collection of blood after blood trauma or after surgery. So, collected blood gets clotted in few minutes or eventually liquefied to become a discolored fluid. So, location, it can be subcutaneous, intramuscular, subfacial, and intra-auricular. So, large hematoma gets infected and form abscess, needs drainage under general or regional anesthesia. Small hematoma usually get absorbed like hematoma. So complications, you have pressure effect, abscess formation, and cosmetic problems. Treatment is incision and drainage, and the concept is spontaneous hematomas occur in individual with coagulation disorders and anticoagulation drug therapy. Okay, so moving on, we have phases of wound healing. You have inflammatory phase, proliferative phase, and we have a remodeling phase, which is a maturation phase. These are the three phases of wound healing. So inflammatory phase begins immediately and lasts for 72 hours, and it is a lateral arterial alveolar constriction leading to platelet aggregation leading to thrombus formation. Later, vasodilation and increased vascular permeability develops. If it happens in a sequence of hemostasis, coagulation, which lead to hemostasis, and all these causes features of acute inflammation: rubor, calor, tumor, dolor, and loss of function. Then we have a proliferative phase, which begins from third day and lasts for 3 to 6 weeks, forms granulation tissue and repairs the wound. Granulation tissue contains fibroblasts, collagen, and neocapillaries. It happens in a sequence. You have initial angiogenesis due to VEGF and fibroblast, which is formation of collagen leading to reepithelialization. So remodeling phase, it begins at 6 weeks, lasts for 6 months to 2 years. Maturation of collagen occurs by cross-linking, and realignment of collagen fibers along the line of tension occurs. Type 3 collagen is replaced by type 1 collagen. There's a different variety of scar strength. First week is 3%, second week is 20%, and 12th week you have 80%. So factors affecting wound healing, you have local factors and you have systemic factors. So damn, the color bleeds into it. Okay, so we have local factors. Yeah, if there is like okay, just a second. So inflammatory phase, inflammation occurs, hemostasis, coagulation, chemotaxis will occur, pathogenesis, lateral initial arterial or vasoconstriction leading to platelet aggregation and thrombosummation, later vasodilation and increased permeability develops. So, hemostasis, coagulation, hemostasis, formation of inflammation. This is from 72 hours. Then proliferative phase from third days, which is 72 hours, lasts for 3 to 6 weeks. So granulation tissue, fibroblasts, collagen, neocapillaries, it occurs in a sequence. You have initial angiogenesis due to VEGF, which leads to fibroblastia, formation of collagen, and you have reepithelialization. So remodeling phase, it is a maturation phase beginning at 6 weeks and lasting for 6 months to 2 years. So maturation of collagen occurs by cross-linking, and realignment occurs along the line of tension. Collagen 3 replaced by type 1 collagen. Scar strength is also there. First week is 3%, second week is 20%, third week is 80%. Type 3 replaced by type 1 collagen. So factors affecting wound healing, you have local factors: ischemia, infection, ischemia, foreign body, hematoma, persistent movement, mechanical stress, necrotic tissue. Then you have systemic factors like diabetes, radiation, extremities of age, hypothermia, hypoxemia, hypocholesterolemia, hyperglycemia, malnutrition, vitamin C and vitamin A deficiency, zinc and iron deficiency, drugs like steroids and doxorubicin, and jaundice. And then you have crush syndrome due to crushing of muscles causing extravasation of blood and release of myohemoglobin into circulation. Then it leads to acute tubular necrosis and acute renal failure. It is caused by earthquake, road traffic accident, mining accident, industrial accident. So pathogenesis. So crush increases tension in muscle compartments, which impedes the circulation, leading to ischemic damage, leading to release of myohemoglobin and toxic proteins, leading to damage to kidneys. Then you have clinical features, which is urine discoloration, patient becomes restless and uremia is seen. Then you have effects of crush injury, you have renal failure, toxemia, septicemia, gas gangrene, extensive tissue loss. You have treatment fasciotomy, you have multiple parallel deep incisions to relieve tension. You have rheomacrodex and mannitol given to improve the urine output. You have urine alkalization using sodium citrate and sodium bicarbonate, which increases the solubility of acid matter and promotes excretion. You have hemodialysis, antibiotics, and correction of severe hyperkalemia. So yeah, that is the crush syndrome. Increases the muscle tension, impedes circulation, ischemic damage, release of myohemoglobin and toxic proteins, damage to kidney. So urine discoloration is there, restless patients, and uremia is seen. So effects of crush injury: renal failure, toxemia, septicemia, gas gangrene, extensive tissue loss. So fasciotomy, multiple parallel deep incisions to relieve the tension, rheomacrodex and mannitol. Just a second. Just a second. Mm. Mm-hmm. I had to get something now. Just a second. Okay. Mhm. Okay. So coming back, sorry about that. You have treatment is fasciotomy and you macrodex and mannitol, which is given to improve urinary output. And you have urine alkalization using sodium citrate and sodium bicarbonate. Increases solubility of acid amidin and promote excretion. And you have hemodialysis, antibiotics, correction of serum urine. Then you have hypertrophic scar, which is excessive formation of abnormal tissue containing containing type 3 collagen, often raised but confined within the margin of original wound. Usually, its growth stops in 6 months and regresses spontaneously. It occurs anywhere in the body, not genetically predisposed. Growth limits up to 6 months, not exaggerate beyond the original scar margin, and response variable for steroid injection. Excessive formation of abnormal scar tissue. Type 3 collagen is seen, often raised, confined within the margin of original wound. Growth stops in 6 months and regresses spontaneously. Occurs anywhere in the body, not genetically predisposed. Growth limits up to 6 months, will not extend beyond. Just a second. Mm-hmm. 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 Mm. So growth limited up to 6 months. It will not extend beyond the original scar margin, and responses variable response. And yeah, complications, often scar breaks causing infection and pain. After repeated breakdown, turns into marginal ulcer. Treatment, you have pressure garments, excision of scar and closure, and triamcinolone injection. So triamcinolone. Then you have keloid, which is excessive, abnormally stretched collagen tissue bundles extending beyond the original scar margin. So features, it is most common in blacks, most common in females. It is genetically predisposed, detected in maturation and stabilization of collagen fibrils. Keloid may continue to grow even after 6 months, and recurrence after excision is more than 50%. It is associated with ehlers and scleroderma. Contents are proliferating immature fibroblasts and proliferating immature blood vessel type 3 collagen stroma. So it located most commonly around the sternum, upper arm, chest wall, and lower neck. So it can also be a hypertrophic scar, but hypertrophic scar, of course, growth up to 6 months, not genetically predisposed, occurs anywhere. It will not extend beyond the original scar margin, whereas here it may grow even after 6 months, and it's not limited to the scar margin by any means. It may response is variable with steroid element. This is a steroid injection. Okay, triamcinolone is a steroid injection, and you have excision of scar and closure will be there. Okay, so keloid is excessive, abnormally stretched collagen tissue bundles extending beyond the original scar margin. Most common in blacks, females, genetically predisposed. There is defect in maturation, stabilization of collagen fibrils. Keloid may continue to grow even after 6 months, and recurrence after excision in more than 50%. It is associated with ehlers and scleroderma. Contents is proliferating immature fibroblasts, immature blood vessels, and type 3 collagen stroma. Sternum, upper wall, chest wall, lower neck, all of them are sites. You have hypertrophic scar also. Just a second. Hmm. Continue with hypertrophy scar. You have treatment which is intracellular triamcolone. Same as for hypertrophy, it reduces fibroblast proliferation and collagen synthesis. And you have silicone gel sheeting, NDYAG laser, vitamin E, palm oil massage, and excision and skin grafting. And this is very much abnormally stretched collagen tissue bundles extending beyond the original skin margin. Features most common in blacks, females, genetically predisposed, mature, defect in maturation and stabilization of collagen fibrils. Keloid may grow even after 6 months, and recurrence is after excision is more than 50%. That much you must remember. Associated with ehlers-danlos, scleroderma contains are proliferating immature fibroblasts, proliferating immature blood vessels, and type 3 collagen stroma, and compartment syndrome. Okay, contents I have told, sites I have told, hypertrophic scar, it may be treatment is triamcolone, intrakeloidal triamcolone, silicone gel sheeting, NDYAG laser, vitamin E, palm oil massage, and excision and skin grafting. So, compartment syndrome, let's move on. Syndrome is due to increase intra-compartmental pressure within a limited space of area. It is caused by tight dressing or plaster cast, lying on one limb in comatose patient, trauma like fractures, ischemic injury, hematoma, burn injury, etc., gunshot, and snake bite. Features here compromises circulation, compromises function of muscle and muscle ischemia in more than 4 hours, causing muscle death and myoglobinuria, nerve ischemia in more than 8 hours, causing irreversible nerve damage, and you have diagnostic sign which is persistent severe pain, aggravates by passive muscle stretching. Then symptoms you have pallor, pulselessness, pain, paresthesia, diffuse swelling, cold limb, and upon progression you have gangrene for chronic ischemic contracture. Complications you have infections, septicemia, renal failure, gangrene, and ischemic contracture. Treatment you have fasciotomy so that adequately lengthy incision through the deep fascia done until underneath muscle bulges out properly. And antibiotics and hyperbaric oxygen, mannitol, which leads to diuresis. Also, it is a break in the continuity of the covering epithelium due to molecular death. Parts you have margin, floor, base, and edge. It is regular or irregular, over-rounded or oval. Floor contains discharge, granulation tissue. Base is upon which the ulcer rests, soft tissue or bone. And edge is the sloping edge seen in healing ulcer, undermined edge seen in tuberculous ulcer, punched out edge seen in syphilitic ulcer, raised and beaded edge in rodent ulcer, and inverted rolled out edge seen in carcinomatous ulcer. Different types of ulcer and its causes. But before that, one second. This might be an important point. Okay, muscle ischemia, if it is more than 4 hours, if it's more than 8 hours, for more than 4 hours causes muscle death and myoglobinemia. More than 8 hours is irreversible nerve damage. Okay, diagnostic sign is persistent severe pain with aggravates by passive muscle stretching if the muscle is stretched passively. Symptoms pallor, pulselessness, pain, paresthesia, cold swelling, whole limb, and upon progression, it may become gangrenous chronic ischemic contracture. Infection, septicemia may occur, renal failure may occur, and gangrene and ischemic contracture may occur. Place a fine catheter in the compartment. If more than 30 mm Hg, it is fasciotomy you have to do. Antibiotics, hyperbaric oxygen, mannitol, and then there is a sleep perform. This is all the different type of ulcers, induration of ulcers, break in the continuity of the covering epithelium due to molecular death. Due to molecular death, everyone will forget of. Break in the continuity of epithelium, everyone will say. Okay, parts of ulcer, you have margin, floor, base ulcer and all. Okay, going on, you have induration of an ulcer. Induration is a palpatory sign. There is a specific type of hardness in the diseased tissue. It is observed in long-standing ulcer with underlying fibrosis. Outermost part is the point from which the clearance of wide excision is planned. Stages of ulcer healing, you have stage of extension. The floor is covered with purulent discharge and you have an inflamed edge. You have stage of transition. Floor shows healthy granulation tissue and serous discharge. Then you have stage of repair. You have fibrosis, collagen deposition and scar formation. Clinical classification, you have spreading ulcer, you have healing ulcer, and you have a non-healing ulcer, and you also have a callus, which is a stationary ulcer. So spreading ulcer, the edge is inflamed, irregular and edematous. It is acute painful ulcer. The floor does not contain healthy granulation tissue. Granulation tissue may be absent and has profuse purulent discharge. Regional lymph nodes are enlarged and tender due to inflammation. So healing ulcer, you have a sloping edge with healthy pink granulation tissue. Floor is scanty or minimum with serous discharge. Surrounding areas do not show any sign of inflammation or induration. 3 zones are observed. Innermost zone bluish, middle bluish zone, and outer whitish zone. Innermost red zone is healthy granulation tissue, middle blue zone is growing epithelium, and outer white zone is fibrosis and scar formation. That is the healing ulcer. 3 types of zones are present. Floor is having scanty serous discharge. Profuse purulent bleeding in purulent discharge in spreading. Regional nodes are helpful, acute painful ulcer, and edge is inflamed and edematous and irregular. Healing ulcer, you have sloping edge, healthy pink granulation tissue. Floor, you have scanty or minimum serous discharge, and surrounding areas do not show any signs of inflammation of induration. Okay, so healing ulcer, you have a chronic ulcer depending on the cause. Edge, which is punched out, it is a trophic ulcer. Undermined is tuberculous ulcer, rolled out is carcinomatous ulcer, and beaded is rodent ulcer. And floor, you have it contains healthy granulation tissue and purulent blood is discharged. Callus, stationary ulcer, it is a chronic. Non-healing ulcer, edge is indurated and floor is unhealthy white granulation tissue. and scanty serous discharge. Depending on the age, it is a non-eating ulcer. The main is tuberculosis. Rolled out is carcinomatous and beard is rodent ulcer. Floor, it contains healthy granulation tissue and purulent or bloody discharge will be there. Callus is stationary ulcer. Chronic non-healing ulcer. Edge is indurated. Floor is unhealthy, white granulation tissue. Scanty serous discharge is there. Ulcer does not show any tendency to heal. Healing is, of course, granulation tissue is there, healthy granulation tissue, growing epithelium, white out its own, scar formation, fibrosis. So, based on duration, acute ulcer lasting for less than 2 weeks, chronic ulcer lasting for more than 2 weeks. And pathological classification, you have specific ulcer, malignant ulcer, and non-specific ulcer. Specific for TB, syphilis, actinomycosis, and malarious ulcer. Malignant ulcer is carcinomatous, BBC, rodent ulcer, also called as carcinoma, basal cell carcinoma. And you have non-specific ulcer like traumatic ulcer, venous arterial ulcer, venous ulcer, trophic ulcer, infective ulcer, cortisol ulcers, Basin's ulcer, diabetic ulcer, Mortalis, hypertensive ulcers seen in the calf, frostbite, and ulcers due to leukemia, polycythemia, and jaundice, etc. We also have vagueness grading of ulcer 0, 1, 2, 3, 4, 5. 0 is pre-ulcerative lesion or healed ulcer. 1 is superficial ulcer. 2 is ulcer exposing soft tissue or bone. 3 is abscess formation of osteomyelitis. 4 is gangrene of a patient of area or limb, part of the limb or the area. And 5 is gangrene of entire area or limb. Different types of discharge are there. Healthy is serous ulcer. Purulent is infective ulcer. Bloody is malignant ulcer. Healing ulcer with healthy granulation tissue. Seropurulent is also there. Serosanguinous is serous and blood. Serous with sulfur granules is actinomycosis, and yellowish discharge is tuberculous ulcer. So granulation tissue is proliferation of new capillaries and fibroblasts with fibrin cover over it. So you have various types of it. You have healthy granulation tissue, you have unhealthy granulation tissue, and you have unhealthy pale flat granulation tissue, exuberant granulation tissue which is proud flesh. You have pyogenic granuloma. All of these types of granulation tissues are there. Healthy granulation tissue occurs in healing ulcers. Sloping edges will be there. Serous discharge will be there. 5P will be there, which is pink, punctate, pulseful, painless, and pinhead granulation. Unhealthy granulation tissue is pale with purulent discharge. Edge is inflamed, edematous. It is a spreading ulcer. Unhealthy pale flat granulomatous tissue is seen in chronic non-healing ulcer, callus ulcer. So, granulation tissue protrudes out of the sinus opening or ulcer blade associated with retained foreign objects in the sinus cavity. Pyogenic granuloma is protruding granulation tissue presenting as well as a local red swelling which bleeds on touch. And then investigations here: study of discharge, culture and sensitivity, acid fast, AFB study, acid fast bacilli study. Wedge biopsy you can perform, taken from the edge, contains multiple cell, taken from two sides, and it's not taken from center as it contains necrotized tissue. So then X-ray, you use it to look for periostitis, osteomyelitis, chest X-ray, Montaus test in case of TB suspicion. Management, you have debridement, removal of exuberant granulation tissue, ulcer dressing, vacuum assisted therapy, and maggot debridement therapy, amnion, chorion. And once ulcer granulates, defect is closed with secondary suturing and skin grafts or flap. So debridement, it is removal of devitalized tissue. Creflavin, it is a irritant, de-slows and promotes granulation tissue formation. Maggots, removed using turpentine solution. Hydrogen peroxide to clean the ulcer. Povidone iodine, iodine is controversial. Remove the exuberant granulation tissue. Ulcer dressing you. Semi-permeable polyurethane films, hydrocolloids, hydrogels, hydroactives, and impregnates. Vacuum assisted closing therapy, it is creation of negative pressure, continuous or intermittent over the wound surface, reduced fluid in interstitial space, reduces edema, promotes formation of healthy granulation tissue. Sterile foam is placed over the ulcer bed, tube train is kept within it, suction is maintained initially continuously, later it is intermittently maintained. Maggot debridement therapy is used as a biotherapy, placing cultured live disinfected maggots act by dissolving and engulfing dead necrotic tissue. They can indicate many bacteria including MRSA. Do not write about this. This is not completely sure if it's being performed in India, but don't write it. Okay, so the different types of ulcers I'll do later, and we'll start with infectious diseases and other class after I'm done with my dinner. And I noticed screensaver has not been turned off. I mean, it had to happen one or the other day. I'll teach you what ulcers again some other time. Okay.